Bismillahirrahmanirrahim. Today my topic of presentation is integrated management of newborn and childhood illness. Life consists of 2 days, one for you and one against you. So when it is for you, you don't be proud or reckless, and when it is against you, be patient, for both days are tests for you. Hazrat Ali Raziyallahu Anhu. The learning objectives, introduction of IMNCI, aims of IMNCI components, principles of IMNCI program, IMNCI process, guidelines and recent trends in IMNCI. Learning outcome. By the end of this presentation, participants will be able to describe the introduction, aims, components, principles and guidelines of integrated management of newborn and childhood illness. Introduction. 10 million children per year die in developing countries due to acute respiratory tract infection, diarrhea, measles, malaria, and malnutrition. 3 out of 4 these children suffer from one of the 5 conditions. Integrated management of childhood illness is therefore a systematic approach to focus on the child health as a whole child. This approach was developed by United Nations Children Fund and WHO in 1995. It includes both preventive component on the part of families and communities as well as creative actions taken by healthcare workers. Pakistan adopted this strategy as IMNCI. What is IMNCI? It is integrated approach to childhood that focus on the well-being of whole child. It also includes both curative component that are implemented by families and communities and as well as health facility. It offers a holistic approach to manage childhood morbidity through 3 components. IMNCI in Pakistan. Pakistan is implementing this strategy since late 19, but not all the required scale. Since 2001, it has only been implemented in 10 districts across Pakistan. Objective of IMNCI. The objective of IMNCI is to reduce the mortality, reduce frequency and severity of illness and disability, improve growth and development during first 5 years of child life. There are 3 components at which the IMNCI is basically focused: health worker component, improvement in overall health system, improvement in family and community healthcare practices. And this integration system actually operates at 3 levels: at the patient level, healthcare system level, and community level. At health worker component, actually is the patient level, which include the improvement in case management skills of the healthcare workers. For example, improve training, guidelines, and skilled case management. In health service component or health system level component, there is need improvement for effective management. For example, there are more health workers in identify referral, swiftly transfer referral center supervision and monitoring, and as availability of essential drugs. Now, difference between IMNCI and MCI. The WHO UNICEF IMNCI is coverage of 0 to 6 days. Early newborn period is targeted in IMNCI but not in IMCI. Basic healthcare module is covered in IMNCI. Home visit by the provider for newborn and young infant is covered by IMNCI. Training of home-based care is also covered in IMNCI. Training days for newborn and young infant is 4 out of 11 days, and in IMCI it is 2 out of 11 days. Sequencing of training: the WHO IMNCI program target the child 2 months to 5 years of age, then young infant 7 days to 2 months of age, whereas IMNCI target newborn and young infant 0 to 2 months, then children from 2 months to 5 years of age. Guidelines of IMNCI. IMNCI is moved from evidence-based and endemic approach to case management, which includes rational, effective, and affordable use of drugs and diagnostic tools. An evidence-based endemic approach can be used to determine health problems of child, severity of child condition, action that can be taken to take care for child. In addition, IMNCI promote adjustment of intervention to the capacity of health system and active involvement of family members and community in healthcare process, which is actually the community component of IMNCI, which include increasing the awareness, awareness among the family members and community. Then what is the rationale for evidence-based and numeric approach to case management in IMNCI? Actually, many well-known prevention and treatment strategies, old in the, for example, childhood vaccination and oral rehydration therapy has been successful effective for saving live children in past in decades, and effective antibiotics have also saved pneumonia. And prompt treatment of malaria also allowed more children to recover. Even modest improvement in breastfeeding practices have reduced childhood deaths. But accumulating evidence suggests that the more integrated approach to manage sick child is needed to achieve better outcome. Because child health programs are vertical programs which only deal with single disease and focusing, and the vertical program is also weak, and they are also and or we need to move beyond single disease because overall address the well-being of child, because many children present with overlapping signs and symptoms of disease. A single diagnosis can be difficult and may not be feasible for appropriate, and this is especially true for first level facilities where examination involved few instruments. Therefore, to tackle this problem, in mid 1990s, WHO, in collaboration with UNICEF and many other agencies, institute and individuals responded to this challenge by developing a new strategy known as integrated management of childhood illness. Now, principle of IMNCI. First principle is all sick children under 5 years of age must be examined for conditions which indicate immediate referral to hospitals. Principle 2. Children must be routinely assessed for major symptoms, nutritional and immunization status, feeding problems, and other potential problems. Only a limited number of carefully selected clinical signs, which are based on evidence of their sensitivity and specificity to detect disease. Based on the presence of selected clinical signs, the child is classified, placed in classification. Classification are not specific diagnoses but are categorization that are used to determine the treatment. Principle of integrated care. A combination of individual signs leads to child classification rather than diagnosis. It is achieved by color code triage system, in which the pink color indicates needs urgent hospital referral or admission, which is classified as pink color coded. Yellow indicate medical diagnosis or advice, which is indicated by yellow color, and the green color indicate the classified as green color as need management at home. Principle 6 is limited number of essential drugs are used. Caretakers are actively involved in treatment of children. Counseling of caretakers about home care, including feeding, fluids, and when to return to health facility. Therefore, the principle of integrated management is to cover sick children up to 5 years of age, look for general danger sign, and identify the children which have very severe disease, and assess for main symptoms, for example, cough, diarrhea, fever, early infection, local bacterial infection, diarrhea, and jaundice. Routinely check for nutritional immunization status, HIV status, other potential problems. Only limited number of clinical signs are used. Combination of classification should be used, and IMNCI should use a limited number of essential drugs, and there should be appropriate counseling of caregivers. Goals of IMNCI is the standardized case management of sick born and children, focus on the most common cause of mortality, nutritional assessment and counseling for all sick infants and children, home care for newborns to promote exclusive breastfeeding, prevent hypothermia, improve illness recognition, and timely care seeking. IMSCI case management process include, first of all, assess the child for danger sign or any other symptom, then classify the disease, identify the treatment, whether the treatment at home and emergency treatment required or at health facility, treat and then counsel the mother and then follow up services. IMNCI package. IMNCI package guidelines recommend standardized case management, which is mainly targeted on two age categories up to 2 months, 0 to 2 months, and 2 months to 5 years. Care of newborn and infants under 2 months, keeping the child warm, initiation of breastfeeding immediately after birth, and counseling for exclusive breastfeeding and non-use of pre-lacteal feeds, cord, skin, and eye care, recognition of illness in newborn and management, immunization, home visit in postnatal period, care of infants from 2 months to 5 years, management of diarrhea, acute respiratory tract infection, malaria, measles, acute ear infection, malnutrition, and anemia, recognition of illness and at risk and management and referral, prevention and management of iron and vitamin A deficiency, counseling on feeding for all children below 2 years, Counseling for feeding for malnourished children between 2 to 5 years of age and immunization. The integrated case management process includes looking for danger signs which include convulsion, lethargy, uneasiness, or unable to feed, vomiting. Assess main symptoms: cough, diarrhea, fever, ear problems. Assess nutrition, immunization status, and potential feeding problems. And also check for the other problems. Then classify the condition in the children and assign to one of three color codes. Identify the treatment action as per need listed in the color band. For example, the pink is required urgent referral and provide pre-referral treatments. Advise parents refer the child at the referral facility for diagnosis, treatment, and monitoring and follow-up. Or a child requires yellow color code which indicate treat at the OPD, treat local infection, give oral drugs, advise teach and mother and follow-up. Home green color code home management which include counsel caretaker how to give oral drugs, treat local infection and home continue feeding, danger signs and follow-up. This further include assess, classify, identify, treat, counsel the mother and provide follow-up care. What does IMNCI actually offer? It actually include assessment and classification of all children presenting to physician, initiating treatment of all children, include the counseling, initiate drug treatment, pre-referral treatment, and referral advice for serious condition management when referral is not possible. What it does not offer: severe pneumonia, severe febrile illness, severe malnutrition, severe persistent diarrhea, care at birth for all newborns, management of birth asphyxia, and emergency triage and treatment system. AIDS in IMNCI guideline. AIDS is not as specifically addressed in IMNCI, but when a child who is believed to have HIV positive present with any of these common illness, he can be treated like any child coming in with illness for first time. If child illness does not respond to standard treatment, or child becomes severely malnourished, return to clinic repeatedly and is referred the child for special care clinic which is indicated for HIV care. Now, according to the guidelines and management of disease which is covered in IMNCI, first of all, from 0 to 2 months, assess, classify, and treat the sick young infant up to 2 months. For example, ask the child if this has infant difficulty in feeding or look and sign about the breathing and count and their chest enjoying or not, auxiliary temperature measured, infant move or not, and or stimulated also, and then therefore classifying the sign and identify the treatment. For example, pneumonia, if the child has fast breathing 60 breaths per minute in the last 7 to 59 days, it is known as pneumonia and give infant amoxicillin and advise the mother to home care, feed up for 14 days. If there is umbilicus or drainage or local infection, give amoxicillin for 5 days and treat the mother and also counsel. If there is no sign of bacterial infection or very severe disease, then it is green, which is severe disease or urgently unlikely. Advise mother to give home care to the young infant. Then we can also check for jaundice. For example, any jaundice less than 24 hours or yellow palm or sole at any age represent the severe jaundice, which can urgently refer to the child to hospital and also prevent the blood sugar. Jaundice appearing after 12 or 24 hours of age, palms and sole, not yellow, it is jaundice, not severe jaundice. Therefore, advise the mother to take care for home. Immediately return if palms and sole become yellow. Follow up in 2 days. No jaundice indicate, advise the mother to give home care for the young infant. Then also there is a classification of severe dehydration, some dehydration and no dehydration. Severe dehydration indicate movement only when a child not movement is stimulated at all, sunken eyes, skin pinch goes back very slowly indicate longer than 2 seconds. Then classify child has severe dehydration. Follow plan C to treat severe, which includes start IV fluids immediately, refer urgently to hospital, and advise mother to continue breastfeeding and sips of ORS during the way. Some dehydration indicate restless and irritable child, sunken eyes, skin which goes back slowly, not very slowly. In this infant does not have severe classification, refers give fluid and milk for some dehydration is plan B, which include advise mother to continue breastfeeding, and if the infant has also another severe classification, refer gently to hospital, advise mother when to return immediately. If not enough sign and classified some not severe dehydration, there is no dehydration, give fluids and breastfeed to treat diarrhea at home, which is a plan A, and advise mother to return immediately when danger sign appear. There is also classification for low birth weight or feeding problems and no feeding problem. For example, in feeding problem, low birth weight, there is not well attached to breastfed, not suckling effectively, less than 8 breastfed in 24 hours, receives other food, low birth weight, forage or thrush. These indicate feeding problem, low birth weight. If not feeding attached, then treat the uh, treat, identify, classify and treat to prevent low blood sugar, refer urgently to hospital. Teach the mother to keep the young infant warm on the way to hospital. Then there is no low weight for age and no other signs of inadequate feeding, no feeding problem. Advise mother to give home care for young infant and place the mother for feeding the infant as well. There is also very low weight feeding problem or low no feeding problem and very low weight if the weight is less than 1.5 kilogram or minus 3 z-score on growth chart, then treat the low blood sugar, refer urgently to hospital. Feeding problem or low birth for weight for age, counsel about the mother. If thrush, teach the mother to treat it at home. Follow feeding problem or thrush on 3 days. Follow up on low weight for age on 7 days. If not low weight for age and no other signs of inadequate feeding, no feeding problem, advise the mother to continue feeding and ensure good hygiene. Also check the infant mutational status, see immunization status according to PI, age at birth, BCG or hepatitis 0 or OPV 0, 6 week, DPT, HB1, HB1, OPV1, rotavirus 1, pneumococcal conjugate virus, and similarly 10 weeks also check, give all missed dose on the visit, check immunization status, and immunize all sick infant unless being referred, advise the caretaker when to return for next dose. Vaccination should be provided in line with national immunization guidelines, but young infants who are HIV positive, unknown HIV status is symptom consistent with HIV should not be given BCG and given all other vaccination but not given BCG. Feed the young infant and counsel the mother. If the young infant is classified as possibly severe bacterial infection or very severe disease, give pre-referral treatment and refer urgently, which include the first dose of IM, gentamicin, and oral amoxicillin. Treat the young infant to prevent low sugar level. If mother is breastfed, ask mother to continue breastfeeding. If infant is not able to breastfeed but is able to swallow, then give 20 to 50 ml express breast milk before departure and continue feeding by NG tube is not taken by mouth. Teach the mother how to keep the young infant warm and provide skin to skin contact care and provide counseling. Refer urgently if the some dehydration, severe dehydration, and if the child is not able to drink. Treat the young infant with severe dehydration quickly with Plan C, which include IV fluid start. Refer urgently to hospital for IV fluid. Start rehydration by tube with ORS. Where referral is refused or not possible, further assess and classify the young infant with possible serious bacterial infection, very severe illness, for example, critical illness, clinical severe infection, or severe pneumonia. In critical illness, the first dose of antibiotic explained to caregiver at the infant is very sick and needs urgent referral. Treat to prevent low sugar level, refer urgently to hospital. In clinical severe infection, explain caretaker the infant is very sick and needs urgent referral. If referral is not possible, treat at OPD clinic with daily IM gentamicin, give oral amoxicillin for 7 days, teach the mother how to give oral drug, advise the mother to return to next injection tomorrow, and also treat any other classification. In severe pneumonia, which include fast breathing, 60 breaths per minute, or infant less than 7 days, give amoxicillin for 7 days, teach the mother how to give oral amoxicillin twice daily, and also return when referral is refused or not possible, treat the young infant who has clear severe infection, include IM, gentamicin, and oral amoxicillin. Give pre-referral treatment to young infant whose critical illness and urgent refer. Give first dose of intramuscular gentamicin and amoxicillin to young infant with critical illness and refer urgently to hospital. Treat the young infant. Teach the mother to give oral medicine at home. Determine appropriate medicine. Tell the mother the reason to give the medicine. Demonstrate how to measure a dose. Ask the mother to give a first dose. Treat the young infant and counsel the mother. Teach the mother how to treat local infection at home. For example, to treat skin pustule or glycal, mother treatment twice daily for 5 days. Wash hands gently. Wash off the pus. Dry the area. Paint the skin or umbilicus with full strength gentamicin, gentian, violet lotion. Wash hands again. immunize and child which has thrush or oral ulcer also counsel the mother to wash hand, paint the mouth with full strength gentian violet using a clean and soft wrapped around the finger. Immunize every sick child as needed. Treat the infant and young. Counsel the mother. To treat the young infant with diarrhea, give extra fluids and continue feeding. And treat diarrhea at home through Plan A, which include counsel the mother, give extra fluids when to return, breastfeeding frequently, give ORS, and it is important to give ORS at home. Teach the mother how to mix and give ORS. When the child has some dehydration with ORS, then Plan B is followed, which include give recommended in clinic amount of ORS over 4-hour period, determine amount of ORS to give during first 4 hours and show the mother how to give ORS after 4 hours. Reassess the child and classify the infant for dehydration. Begin breastfeeding the infant in young infant in clinic. If the mother must leave before completing treatment, show her how to prepare ORS home and continue. Explain the rules of home treatment for young infant. Counsel the mother, teach the mother for correct position attachment for breastfeeding, teach the mother how to feed by the cup, teach the mother how to express the breast milk. Counsel the mother, teach the mother how to keep the low birth weight warm at home, and advise birth skin to skin contact, avoid bathing the low birth weight infant, change clothing whenever they were wet, provide skin to skin contact where as possible. When not the skin is contact, keep the young infant clothed or cover as much as possible at all the time. Check frequently if the hand and feet are warm. If cold, re-warm the baby using skin to skin contact. Breastfeed the infant frequently. Counsel the mother also care for home exclusive breastfeeding the young infant for breastfeeding mother and make the sure child is kept warm at all the times. When to return immediately, breastfeeding poorly reduced activity becomes sicker, develop a fever, feels unusually cold, develop fast breathing, develops difficult breathing, palms or yellow sore. Now follow-up care, clinical severe infection, referral was refused or not possible, or the child become worse. There is severe clinical infection or signs of clinical severe illness, include pneumonia or severe pneumonia. Follow-up in 4 days, reassess the infant, refer the infant if infant becomes severe and no or any new signs of very severe disease. Give follow-up for a young infant. For local infection, only 3 days treatment of cataplecus and provide the treatment. Jaundice, only 2 days follow-up. Look for jaundice, any palmar sore, yellow or not. Diarrhea on day 3 has the diarrhea stop. If diarrhea is not stopped, assess the child. If diarrhea is stopped, advise the mother to continue breastfeeding. Feeding problem on day 3, reassess feeding problem and check the feeding problem for low birth weight age. Giving follow-up for young low weight for age. If infant is no longer low weight for age, parents and mother encourage continue feeding. If it's still low for age, but feeding is well, ask mother infant weight again within 1 month and when he returns also immunization. It is if the infant is still low weight for age and still has feeding problem, counsel the mother about the feeding. Ask the mother return after 14 days and continue to see the infant every week. Thrush on the day of treatment. If thrush is worse, child has problem with attachment of suckling. If thrush is in the same or better and infant is feeding well, continue full strength gentian violet for total of 7 days. Assess and classify the child about 2 months to 5 years of age. Assess, classify, and identify. For example, severe pneumonia, very severe, any danger sign present, or stridor in calm child with severe pneumonia. Give first dose of appropriate antibiotic and refer gently to hospital. If there is chest indwelling or fast breathing pneumonia, give oral dose of moxicillin and OPD, and for 5 days. Also give bronchodilator. Coughing is more than 14 days or recurrent wheeze. Asthma assessment is also required. Advise mother to return immediately. Follow up in 3 days. If there is no sign of pneumonia or very severe disease, soothe the throat and relieve the cough when a safe remedy. If coughing for more than 14 days, recurrent wheezing, refer for possible TB. Also, severe dehydration, 2 of the following lethargic, unconscious. Refer the child urgently to hospital and advise the mother give sips of ORS. Some dehydration, restless, sunken eyes, skin pitched back slowly. Give the plan B and no dehydration. Give at home treatment. Similarly, very severe febrile disease, um, malaria test positive with first dose of paracetamol in clinic or high fever. When malaria test negative and fever, no malaria test, give recommended first dose of anti-malaria, give oral dose paracetamol clinic and provide treatment at home. Very severe febrile disease, panic, danger sign or sick children, give or one dose of appropriate antibiotic, treat the child low blood sugar and fever, no other signs and no stiff neck, give the first dose of paracetamol, give appropriate antibiotic treatment. Severe complicated measles and measles, severe dengue hemorrhagic fever, and severe dengue is referred to hospital, child hospital, and therefore fever only dengue hemorrhagic fever still. Also classify the child for an ear infection which include mastocytitis, tender swelling behind the ear, acute infection having the pus drainage for less than 14 days, give antibiotic for 5 days, give paracetamol for pain, chronic ear infection for 14 days, man ear infection, treat with topical quinolone for 14 days, and no ear infection, no ear pain and pus draining from ear, no treatment. Similarly, complicated severe acute malnutrition when the weight for height is less than 3 standard deviation or sports or mid-arm circumference less than 115 millimeter. Give first dose of antibiotic and refer urgently to hospital. Uncomplicated severe acute malnutrition. Weight for height is less than minus 3 z-score or mid-arm circumference is less than 115 millimeter. Give oral first dose 5 days and give ready to therapeutic food. Counsel the mother how to feed the child and return in 7 days. Moderate severe acute between minus 3 and 2 z-scores and no acute malnutrition when the weight for height is minus 2 z-score or more. If child is less than 2 years, assess the child feeding, counsel the mother of feeding according to feeding recommendation. Follow up in 7 days. Severe anemia, severe palm pallor, urgent refer to hospital. Some pallor anemia give iron, mebendazole if child is 1 year. No palm pallor, no anemia, child is less than 2 years, assess the child feeding and counsel the mother according to feeding recommendation. Therefore, also check the immunization status, vitamin and D formula status. If any dose is missing, recommend the immunization chart. Here the treatment step, identify and classify the chart. Teach the mother how to give oral drugs at home. Teach the mother to treat local infection at home. Treat these treatment at the clinic. Give these treatment in the clinic. Give extra fluid for diarrhea and continue feeding. Treat diarrhea at home when according to plan B, and if there is some dehydration ORS according to plan B. Give extra fluid for diarrhea and continue feeding. Give vitamin A supplementation. Mean give ready to therapeutic use for severe acute malnutrition. Give follow-up care for acute conditions, for example, pneumonia, persistent diarrhea, dysentery, which include blood in the stool, fever, abdominal pain for more than 3 days, malaria, ear infection, uncomplicated severe acute malnutrition, follow-up after 14 days, moderate acute malnutrition after 30 days, counsel the mother for feeding problem, assess the child appetite in acute malnutrition, explain the mother the purpose of child and what is added to therapeutic food. Give extra fluid and mother's help for every sick infant and child with diarrhea. When to return and follow up. This is IMNCI feeding management chart for up to 2 to 5 years of age. Recent advances include WHO, IMNCI in Pakistan. It is actually integrated global strategy. Pakistan was a pioneer in adopting IMNCI strategy in 2000, which is strategies not to be implemented in wide scale and only major barrier is long training scale and a bridge course is also introduced by WHO to expected to accelerate scale-up of IMNCI across country, but it does not require to be complemented by skill reinforcement, clinical monitoring, and sportive supervision. Integrated management of childhood illness implementation in rural district of Pakistan through lens of planners and implementation. This is a study which is conducted, and this study shows that there are some supporting and constraint factors in implementing the IMNCI program, and in constraint factor mainly consist of discrepancies about implementation, trained physician lack of willingness to practice IMNCI strategy, inadequate logistics support, weak monitoring and supervisory system, lack of awareness, and hindrances in reporting system and corruption in the district health system. Also, there is evaluation of conventional IMNCI training for healthcare workers in 11 days. This is also an experimental study for comparing the training course between standard or average course presented by WHO. Average course is actually 7 days course and standard is 11-day training. This study includes that average course, it is 7 days course, is equally effective, but as the standard training, however, training for certain illness may be better delivered by standard course. Insight into implementation of facility-based integrated childhood illness in rural Punjab. This is also qualitative study which is actually determining the factors which influencing IMNCI implementation, which include that there is lack of sound planning system and leading to ambiguous role and responsibility among stakeholders, and there are some constraint factors, poor planning, understanding of strategy of IMNCI implementation among stakeholders, and availability of essential drugs. Now come to MCQs. A mother brings his 4-year child in pediatric emergency department with the symptoms of headache, nausea, vomiting, and difficulty in speech and loss of balance. Mother also gave history of road traffic accident. On physical examination, there is respiratory distress, blood pressure less than 100 millimeter of mercury, and Glasgow coma scale 10 out of 15. The child should manage according to guidelines of IMNCI integrated emergency or pregnancy childhood postnatal care or emergency obstetric care. C. Correct answer is C. According to trauma care, because any trauma care or head injury is not covered under the IMNCI program. MCQs 2. A public health expert team found that inadequate health system support and lack of trained health staff are main constraint factors associated with implementation of IMNCI strategy in their research project. Which level of integration is improvement in this scenario? At healthcare delivery level, at family and community level, patient and healthcare system level. The correct answer is at the patient and healthcare system level. Because in healthcare system level, main factors are lack of support in healthcare system and lack of trained health staffs, which are required for case management. At infection of sunken eyes, milder no movement at all, and very slow pinching of skin is present. This is classified as IMNCI. Severe moderate, some severe, yes, severe because it is less than 2 seconds. A newly born child aged less than 24 are with history of yellow discoloration of skin, which color in color code by year system of IMNCI is used to classify a childhood illness in this scenario. Yellow, orange, pink, or red.
Red.
Pink, yes, which is also because it is less than 24 years, which indicates severe jaundice. MCQs 5, a 5-month-old child with history of 60 breath per minute, chest and growing, look lethargic and unable to feed. She has severe pneumonia, no pneumonia, very severe pneumonia. Severe pneumonia because chest and growing, fast speaking present, which are all signs of severe pneumonia and IMNCI. A 6-month-old infant child presented in pediatric emergency history of pain and ear discharge for more than 18 days. Which color coding system is used to classify the yellow, orange, green, pink, or red? Yellow because it is more than 14 days, which include not ear infection, not severe infection, but when it is less than 14 days, it includes severe ear infection, which is treated in according to pink. A 12-month-old child looking irritable, restless, and also have sunken eyes, skin pinch goes back less than 2 seconds. The child also had history of loose watery diarrhea for 2 days. Child should give food and fluids only, give zinc supplementation, give first dose of antibiotic, or refer urgently to hospital. With continued breastfeeding and D. Whose child is restless and irritable and sunken eyes, therefore refer urgently to hospital with continued breastfeeding and frequency. A 6-week HIV positive infant presented in pediatric emergency with history of pain and ear discharge for more than 14 days. Child also missed a vaccination of EPI. The doctor should treat the ear infection. No treatment required with OPV and BCG infection vaccination. Delta. Treat the child with ear
T.
and complete all missed doses of EPI except BCG because child is HIV positive. A 9-month-old infant had symptoms of bloody diarrhea with belly cramps, fever, nausea, and vomiting. On examination, child has sunken eyes, mild or no movement at all. The child had dysentery, diarrhea, food poisoning, or salmonellosis.
Dysentery.
4 days bloody diarrhea.
Dysentery.
A 1-year-old child has low appetite and edema for both infants. For 1 week on examination, weight for height less than -3, Z-score and mid-arm circumference less than 115. The child referred to hospital, require no treatment, offer the child dietary therapeutic food.